Hello there, it's Dr. Andy Toy here with another post in the Keep Calm and Carry On Aligning series. As you know, consent is very close to my heart, and I've got another post today based around consent. My last post briefly mentioned the issue of root resorption when you're discussing Invisalign treatment with patients, and how you should put that into the balance so that they understand the relative risk against the benefits of alignment. And for the vast majority, the relative risks are extremely low. Well, funny enough, today I get through the post Orthodontic Update. Now, Orthodontic Update is a 3M sponsored publication. It's edited by the great Jonathan Sandler. You may know him as a consultant orthodontist in Chesterfield, but also he's taught a lot of GDPs on his course, and he is a well-respected authority in the orthodontic world. And in fact, there's an article in there which is co-written by Jonathan, Fatima Rushnare, who is a fifth-year dental student, and Cara Sandler, his daughter. And that's about root resorption, why we all need to get informed consent. So I thought, well, this is very timely. Let's have a good look at this, and maybe there's things in here that can help us with our consent process for patients. So I've had a good look, and there's a case report and then some, it's like a review of the literature, which I think is probably the most significant thing for us. And here we go. So in order to minimize the effects of orthodontically induced external apical root resorption, the risk level of patients should be individually assessed as part of obtaining the valid consent. So as with all consent processes, you really need to know your patient, and that's knowing them clinically as well as obviously socially, medically, and with a dental history as well. It is important to identify the patient-related risk factors prior to commencing orthodontic treatment. Therefore, thorough history taking is essential. Absolutely right. Age and gender are two factors that are suggested to influence this apical root resorption, although one systematic review suggested the resorption occurs irrespective of the patient's age and gender. So I don't really take that into account too much myself. In my adult orthodontics, I assess everybody the same. Other risk factors have been suggested to impact how different individuals experience root resorption. However, there's a low level of evidence to support these findings. So this list of possible factors includes patients with pre-treatment trauma to their teeth. Definitely, I'm going to have a look at any patient. You see a dark central incisor. They can't remember if they had any issues or not, but I'm going to take an x-ray and I'm going to do some pulp testing on that tooth. Endodontally treated teeth, we should see those on an x-ray. Abnormal root length or shape, so that the shape could be pointed, pipette, or dilacerated. Again, you'll see that on your standard x-ray. Agenesis, previous orthodontic treatment. That's a very important one to pick up on with our adult patients, because many of them have had previous orthodontic treatment, especially those with extensive, heavy fixed appliances. Then, if they talk to you about having treatment over 2, 3, 4, 5 years, be thinking about, is there possible root resorption here? And those with increased overjet and overbite and corrected impacted canines. So there you go. There's the impacted canine. That will be in their dental history as well. So all of those. Other things to consider are systemic illnesses, such as asthma, and some medications such as steroids, NSAIDs, that's painkillers, thyroxine, and systemic fluoride. They can also have an impact. Patients taking bisphosphonates, have shown milder root resorption and a slower rate of orthodontic tooth movement. So remember, there's not strong evidence for any of these. They've been suggested. There's probably a lot coming out of clinical experience, but I think it takes back to the fact that you need to do a really thorough history, you and your team, and you want to have a good set of, in my hands, OPG, and if I can't see the anterior teeth, then I'm going to probably take a PA of those teeth as well if my OPG doesn't bring that out. So that way you'll have a good history. I think you then go into the conversation around having with that patient and firstly identifying, have they got short roots? Have they got mobility? And if they have, you're going to have a conversation around, do you really, really need to move these teeth? And if you do need to move these teeth, what would be the consequences if you did lose that tooth? With some of these patients, it's reasonable to say it's got a poor prognosis anyway. So there's a reasonable chance you're going to lose these teeth one day in your life. And in general, if you do lose that tooth, it's going to be easier and more better treatment outcome for all the other teeth that are in the right place. So I let them understand that and think that through. If we are going to move the teeth, then I'm going to try and apply minimal velocity. And you can do that easily with Invisalign if I do need to move the tooth at all. So that is something that Invisalign is easier to apply, I think, in my experience anyway, than with fixed appliances. So there you go. I hope that is helpful to you. You've got a series of risk factors to consider, and also then whether you choose to move that tooth or not. And if you do move that tooth, you apply minimal velocity in a hope that you're going to minimize the stress on those teeth. But it really ultimately is down to the patient and their decision about the potential benefits of alignment against the potential risks. And thankfully, the vast majority of patients, there is no real risk of root resorption with orthodontic treatment. Thanks for listening.